Up to this point, we have been studying cholinergic and adrenergic drugs by focusing mainly on their direct effects on receptors. In other words, we give a drug, it binds to its target receptor, and we expect a predictable textbook response. However, in the human body, things are often not that straightforward. The reason is that the body generally does not like sudden changes in important physiological parameters. Whenever a drug produces a significant and rapid change, the body often tries to oppose that change in order to maintain homeostasis. Take blood pressure as an example. If we administer a drug that causes blood pressure to rise or fall rapidly, the body does not simply accept this new value. Instead, it activates compensatory mechanisms that attempt to bring blood pressure back toward its original pre-drug level. As a result, the final response that we observe may be quite different from what we would predict. Understanding these compensatory responses is extremely important in pharmacology because many drugs are used specifically to alter blood pressure. If the body's own compensatory mechanisms are constantly trying to oppose these effects, then we may not achieve the desired therapeutic effect that we are aiming for. Therefore, in this lecture, we will discuss one of the most important mechanisms responsible for the rapid regulation of blood pressure, the baroreceptor reflex loop. We will first understand why the body needs this reflex and how it helps maintain blood pressure stability from moment to moment. Then we will examine what happens when blood pressure suddenly rises or falls, how the autonomic nervous system responds to these changes, and how these responses can produce reflex bradycardia or reflex tachycardia. Finally, and most importantly from a pharmacological perspective, we will learn how these reflexes can modify the effects of many cardiovascular drugs. First, what's the purpose of a baroreceptor reflex? As we have already discussed, the body continuously tries to maintain blood pressure within a relatively stable range. To do that, it first needs a way to detect when blood pressure changes. This is where the baroreceptors come into play. Baroreceptors are specialized stretch-sensitive receptors located primarily in two strategic locations: the carotid sinus, which is present at the bifurcation of the common carotid artery, and the aortic arch. These locations are not chosen randomly. Both are major arteries situated very close to the heart, allowing them to continuously monitor changes in arterial pressure. Whenever blood pressure changes, the degree of stretch experienced by the walls of these arteries also changes, and the baroreceptors can detect this alteration almost immediately. Once the baroreceptors detect a change in blood pressure, that information must be communicated to the central nervous system so that an appropriate response can be generated. The baroreceptors located in the carotid sinus transmit their signals through the glossopharyngeal nerve, specifically via a branch known as Herring's nerve, while the baroreceptors located in the aortic arch send their signals through the vagus nerve. These sensory or afferent fibers carry information to the cardiovascular centers in the medulla of the brainstem, which acts as the control center for this reflex. After receiving and processing this information, the medulla sends commands back to the cardiovascular system through autonomic efferent pathways. These efferent pathways consist of both sympathetic and parasympathetic fibers. By adjusting the balance between sympathetic and parasympathetic activity, the medulla can rapidly alter heart rate, cardiac contractility, vascular tone, and stroke volume. As arterial blood pressure is primarily determined by two major factors, cardiac output and total peripheral resistance, and furthermore, cardiac output itself depends on heart rate and stroke volume. Therefore, if the body wants to rapidly correct a change in blood pressure, it can do so by altering one or more of these variables. For example, it can change the heart rate, modify the force of cardiac contraction, and thereby influence stroke volume, or adjust the degree of constriction and dilation of blood vessels to alter total peripheral resistance. This is exactly what the baroreceptor reflex does. Now, what is the normal physiological purpose of the baroreceptor reflex? Imagine that you are lying comfortably in bed and then suddenly stand up. The moment you stand, gravity causes a significant amount of blood to pool in the veins of your lower limbs. As a result, less blood returns to the heart, cardiac output begins to fall, and arterial blood pressure starts to decrease. If this decrease in blood pressure were allowed to continue unchecked, blood flow to the brain would be reduced and you could experience dizziness, lightheadedness, or even fainting. Fortunately, this usually does not happen because the baroreceptor reflex responds within seconds. The fall in blood pressure is detected by the baroreceptors, which then signal the cardiovascular centers in the medulla. In response, autonomic output is adjusted to increase heart rate, increase cardiac contractility, and constrict blood vessels. Together, these changes help restore blood pressure and maintain adequate blood flow to vital organs, particularly the brain. Therefore, the primary physiological role of the baroreceptor reflex is to provide rapid, moment-to-moment stabilization of blood pressure whenever sudden changes occur in our daily activities. Now, up to this point, we have been discussing the normal physiological role of the baroreceptor reflex in stabilizing the small fluctuations in blood pressure that occur during our daily activities. But this naturally raises an important pharmacological question. If the body works so hard to maintain blood pressure at a particular level, what happens when we intentionally try to change that level with a drug? For example, imagine a patient with chronic hypertension whose blood pressure is consistently around 150 over 100 millimeters of mercury. If we administer a drug to lower that blood pressure, and if the decrease is sufficiently rapid and significant, the body's compensatory mechanisms may interpret this as a threat to homeostasis and attempt to restore the blood pressure toward the level at which it had been previously maintained. This creates an important challenge in pharmacology. If the body is constantly trying to oppose the effects of our drugs, then how are antihypertensive drugs able to work in the first place? Are there ways to prevent or minimize these compensatory responses? And do these compensatory mechanisms become activated every time we attempt to lower blood pressure or only under specific circumstances? These are exactly the questions that we will begin to answer as we explore the baroreceptor reflex in greater detail and examine its impact on drug therapy. Now let's see what happens when blood pressure suddenly increases. So, when arterial blood pressure rises, the increased stretch of the carotid sinus and aortic arch causes the baroreceptors to fire more rapidly. These signals are then carried through the afferent nerves to the cardiovascular centers in the medulla. After processing this information, the medulla responds by shifting the autonomic balance. Parasympathetic activity is increased while sympathetic activity is decreased. As a result, vagal influence on the heart becomes more prominent, leading to a slowing of the heart rate. At the same time, the reduction in sympathetic stimulation further contributes to this decrease in heart rate and also reduces cardiac contractility. Together, these changes decrease cardiac output, which helps bring blood pressure back toward the level at which it was originally maintained. Therefore, if the rise in blood pressure is sufficiently rapid and significant, one of the most important responses that we observe is reflex bradycardia. Now, consider a patient in shock, severe hypotension, or in anaphylaxis, where our goal is to rapidly increase blood pressure using a vasopressor drug. If that drug causes a large and rapid rise in blood pressure, the baroreceptor reflex may become strongly activated. The body may then respond with marked vagal stimulation and reflex bradycardia. In extreme situations, excessive slowing of the heart can impair cardiac output and potentially worsen the very problem that we were trying to correct. In other words, while the drug is attempting to raise blood pressure, the body's compensatory mechanisms may simultaneously be working to counteract that effect. Now the question arises, can we cancel this reflex bradycardia? Let's see. When the cardiovascular centers in the medulla decide to slow the heart, as we discussed already, the signal does not travel directly to the SA or AV node. Instead, it passes through a two-neuron autonomic pathway. The first neuron, the preganglionic parasympathetic neuron, releases acetylcholine onto nicotinic receptors located within an autonomic ganglion. The second neuron, the postganglionic parasympathetic neuron, then releases acetylcholine onto muscarinic M2 receptors in the heart. It is the activation of these M2 receptors that produces the reflex bradycardia. Now, to cancel the reflex bradycardia, one option would be to block the nicotinic receptors within the autonomic ganglia. This would interrupt signal transmission through the entire autonomic pathway and effectively abolish the baroreceptor reflex. However, this approach is rather non-specific because it suppresses both sympathetic and parasympathetic autonomic activity throughout the body. A more targeted approach would be to block the muscarinic M2 receptors in the heart using a muscarinic antagonist. In this case, the baroreceptor reflex may still be activated, but its final effect on the heart cannot be expressed because the effector receptor has been blocked. Now let's apply this concept. Suppose we administer a drug that produces vasoconstriction and thereby increases total peripheral resistance. As a result, blood pressure will rise. A classic example would be stimulation of alpha-1 receptors on vascular smooth muscle. Activation of these receptors causes vasoconstriction, which increases resistance and elevates blood pressure. However, once blood pressure rises sufficiently, the baroreceptor reflex is activated. The cardiovascular centers respond by increasing parasympathetic activity and decreasing sympathetic activity, producing reflex bradycardia. Therefore, if we want to preserve the blood pressure raising effect of the alpha-1 agonist while preventing the accompanying reflex bradycardia, we can block the parasympathetic effector pathway with a muscarinic antagonist. Alternatively, a ganglionic blocker could also abolish the reflex, although this approach is far less selective because it suppresses autonomic transmission more broadly. That's how we prevent reflex bradycardia. Now let's work through the opposite situation. So far, we have been discussing what happens when blood pressure increases. But in clinical practice, we are often interested in doing exactly the reverse. That is, lowering blood pressure in a patient with hypertension. Imagine that we administer an antihypertensive drug and blood pressure begins to fall. As arterial pressure decreases, the stretch on the baroreceptors is reduced, causing them to fire less frequently. In a sense, the cardiovascular centers in the medulla begin to receive less input from these pressure sensors. The brain interprets this reduced firing as a sign that blood pressure has fallen below the level at which it was previously being maintained. As a result, it responds by decreasing parasympathetic activity and increasing sympathetic activity. This shift in autonomic balance produces an increase in heart rate, an increase in cardiac contractility, and other sympathetic responses that collectively work to restore blood pressure. Therefore, when a drug lowers blood pressure rapidly and significantly, one of the most important compensatory responses that we observe is reflex tachycardia. The purpose of this reflex tachycardia is quite simple. By increasing heart rate, the body increases cardiac output, and by increasing cardiac output, it attempts to push blood pressure back toward its previous level. Interestingly, the body does not distinguish between a normal blood pressure and a chronically elevated one. If a patient has been living with hypertension for years, the body may have adapted to that higher pressure and treats it as the new baseline. Therefore, when we administer an antihypertensive drug and lower the blood pressure, the body's immediate concern is not whether the pressure is healthy or unhealthy. Its goal is simply to oppose the change and restore the pressure toward the level to which it has become accustomed. Consequently, many antihypertensive drugs can trigger a sympathetic-mediated reflex tachycardia that partially counteracts their intended effect. Now, just as we did for reflex bradycardia, let's analyze the pathway responsible for reflex tachycardia. If the cardiovascular centers in the medulla decide to increase heart rate, how does that signal actually reach the heart? Once again, the pathway consists of two neurons. The preganglionic sympathetic neuron releases acetylcholine onto nicotinic receptors within an autonomic ganglion. The postganglionic sympathetic neuron then releases norepinephrine, which acts on beta-1 receptors in the SA node, AV node, and myocardium. Activation of these beta-1 receptors increases heart rate and cardiac contractility, thereby increasing cardiac output. Therefore, if we want to prevent reflex tachycardia, we can interrupt this pathway at two different levels. One option would be ganglionic blockade, but it is not a practical approach in most clinical situations. A much more selective strategy is to block the beta-1 receptors in the heart using a beta blocker. Imagine that we administer a vasodilator drug. Vasodilation increases vessel radius, decreases total peripheral resistance, and consequently lowers blood pressure. A classic example would be stimulation of beta-2 receptors on vascular smooth muscle. Unlike beta-1 receptors, which are primarily found in the heart, beta-2 receptors in blood vessels promote vasodilation and reduce vascular resistance. However, if this fall in blood pressure is sufficiently rapid and significant, the baroreceptor reflex becomes activated. The resulting increase in sympathetic outflow produces reflex tachycardia through beta-1 receptor stimulation in the heart. This is why a beta-1 blocker can be used to suppress the reflex tachycardia while still allowing the vasodilatory effect of the original drug to occur. Now let's think about why this matters clinically. As we know, many patients with hypertension also have underlying coronary artery disease or ischemic heart disease. In such patients, reflex tachycardia can become a significant problem. Remember, an increase in heart rate means an increase in cardiac work, and increased cardiac work means increased myocardial oxygen demand. Therefore, a drug that lowers blood pressure but simultaneously triggers marked reflex tachycardia may inadvertently worsen myocardial ischemia, precipitate angina, or even contribute to a myocardial infarction in a susceptible patient. In other words, while we are attempting to treat one cardiovascular problem, the compensatory response generated by the body may create another. So, whenever we alter blood pressure, we must think not only about the direct effect of the drug, but also about the compensatory responses that will follow. In general, there are two broad ways to eliminate these autonomic reflexes. The first is ganglionic blockade, which theoretically abolishes both reflex bradycardia and reflex tachycardia. The second, and far more clinically useful approach, is to block the final effector receptor involved in the reflex. Thus, muscarinic antagonists can be used to prevent reflex bradycardia, whereas beta blockers can be used to prevent reflex tachycardia. As we move forward into cardiovascular pharmacology, you will repeatedly see drugs being combined or selected specifically to control these compensatory reflex responses and improve overall therapeutic outcomes. The autonomic nervous system is not the only system the body uses to oppose changes in blood pressure. There is another powerful compensatory mechanism that works alongside it, the endocrine system. In fact, when we attempt to lower blood pressure with antihypertensive drugs, the body often responds not only through the baroreceptor reflex, but also through activation of the Renin-Angiotensin-Aldosterone system. Unlike the baroreceptor reflex, which acts within seconds, the RAAS provides a slower but highly effective hormonal response designed to restore blood pressure. Whenever blood pressure falls, renal perfusion pressure also decreases. As a result, the hydrostatic pressure within the glomerular capillaries falls, leading to a reduction in glomerular filtration rate. The kidney interprets this as a threat to adequate perfusion and filtration. In response, the juxtaglomerular cells begin secreting renin. Renin acts on angiotensinogen, a protein synthesized by the liver, converting it into angiotensin 1. Angiotensin 1 is then converted into angiotensin 2 by angiotensin-converting enzyme, primarily within the vascular endothelium. Now, angiotensin 2 has several important actions. Within the kidney, angiotensin 2 constricts the efferent arteriole. This helps the kidney continue filtering the blood properly, even when systemic blood pressure has decreased. However, its effects are not limited to the kidney. Angiotensin 2 also acts on blood vessels throughout the body, producing generalized vasoconstriction. This increases total peripheral resistance, and as we learned earlier, an increase in total peripheral resistance leads to an increase in arterial blood pressure. Imagine that we administer an antihypertensive drug and lower patient's blood pressure. However, the fall in blood pressure also reduces perfusion of the kidney, which activates the Renin-Angiotensin-Aldosterone system. As we have just discussed, angiotensin II causes vasoconstriction throughout the body, increasing total peripheral resistance and pushing blood pressure back upward. But the story does not end there. Angiotensin II also stimulates the zona glomerulosa of the adrenal cortex to release aldosterone. Aldosterone acts on the kidney to increase sodium and water retention. As more sodium and water are retained, blood volume gradually increases. An increase in blood volume increases venous return to the heart, which increases cardiac output. And as we learned earlier, an increase in cardiac output contributes to an increase in blood pressure. Therefore, the RAAS opposes antihypertensive therapy through two mechanisms. Angiotensin II increases total peripheral resistance, while aldosterone increases blood volume and cardiac output. Together, these effects can significantly reduce the effectiveness of blood pressure-lowering drugs. So, broadly speaking, there are two major compensatory systems that oppose our efforts to lower blood pressure. The first is the baroreceptor reflex, and the second is the renin-angiotensin-aldosterone system. Therefore, successful long-term control of hypertension often requires strategies that address both of these compensatory mechanisms. Traditionally, diuretics were used to counteract fluid retention. Today, we also have drugs that directly target the RAAS itself, such as ACE inhibitors and angiotensin receptor blockers, allowing us to prevent the hormonal compensation that would otherwise oppose our antihypertensive therapy. Before we conclude this section, let's revisit an important question. Do these compensatory mechanisms become activated every time we attempt to lower blood pressure, or only under specific circumstances? The baroreceptor reflex is primarily a short-term blood pressure control mechanism. It is most effective in buffering rapid changes in blood pressure that occur over seconds to hours. Therefore, if blood pressure falls suddenly and significantly, baroreceptor firing decreases, sympathetic activity increases, and compensatory responses such as reflex tachycardia are readily observed. However, if blood pressure changes only slightly or decreases gradually over time, the compensatory response may be relatively small and clinically insignificant. One of the most important properties of baroreceptors is a phenomenon known as resetting. If arterial pressure remains elevated for several days, the baroreceptors gradually adapt to this new pressure and begin to treat it as the normal baseline. In other words, instead of continuously signaling that blood pressure is too high, they reset their operating point to the new level. This is one of the reasons why the baroreceptor reflex is excellent for short-term regulation of blood pressure, but relatively ineffective for long-term control. For example, in a patient with chronic hypertension who has maintained a blood pressure of 160 over 100 millimeters of mercury for months or years, the baroreceptors may have partially reset to this elevated pressure. As far as the reflex is concerned, this abnormal blood pressure now feels normal. This concept has important clinical implications. Imagine a patient whose blood pressure has been chronically elevated for many years. If we suddenly reduce the blood pressure to what physiology textbooks would consider a normal value, the patient's body may initially interpret this as a fall in pressure. As a result, the patient may experience symptoms such as dizziness, weakness, fatigue, or lightheadedness because the cardiovascular system and tissue perfusion mechanisms have adapted to functioning at the higher pressure. This does not mean that the lower blood pressure is harmful. Rather, it means that the body requires time to readjust to the new level. For this reason, blood pressure is usually lowered gradually rather than abruptly, particularly in patients with long-standing hypertension. A gradual reduction allows the cardiovascular system, baroreceptors, kidneys, and tissue perfusion mechanisms to adapt progressively to the new pressure. Of course, there are exceptions, such as hypertensive emergencies, where blood pressure must be lowered more promptly. However, even in these situations, clinicians generally aim for a controlled and monitored reduction rather than an immediate normalization of blood pressure. Therefore, in routine hypertension management, the goal is not to lower blood pressure as quickly as possible, but to lower it safely and progressively while allowing the body's compensatory mechanisms time to adapt to the new physiological state.